What are we doing? We're hitting with more healthcare costs for employers. I just gave that example about where you've got to have a higher percentage. You've got mandates on employers to provide insurance, those kinds of things add costs for employers. You've got fines, requirements for health insurance coverage, taxes and fees, and it depends on which bill. When you think about taxing so-called people making $200,000 or $300,000, for a lot of us that sounds like a lot of money, but if you're a small business person and your income flows, your business income flows through your personal, that ain't so much after all. And the job growth in America is largely small businesses. And a lot of these things nail small business big time. There's a higher share of requirement, I mentioned that before, going typically from the 50% requirement to, depending upon business size, up to 70-some% of the premium costs have to be absorbed by the employer. And then there's all kinds of additional record keeping. Just what we need is more record keeping and bureaucracy. Next. This is another one. I happen to believe that the number one powerful solution in healthcare reform that would make a difference in cost is all about consumers. And Dr. Wright talked a lot about it. He's absolutely right. The big disconnect between the consumer and the actual cost is one of the reasons why we've had these spiraling inflation. It doesn't mean we all do the wrong kinds of things, but if the cost of a prescription for most of us is, we think, $10, when in fact that bottle actually cost $1,000, and oh, by the way, there probably was a generic, and this is hypothesis, but it happens a lot, that might have, behind the scenes, cost you about the same for a copay, but might have cost your health care about $100, or maybe even less. We haven't had motivation to make those kind of analyses. As we have had the influx of things like health savings accounts, and I've had testimony after testimony from people telling me how it's changed behaviors in their companies when they've implemented health savings accounts. Why? Because people had the audacity to ask, how much is this MRI going to cost? And they found out that it's different from one provider to another provider. And you don't think that influences the market? Look at LASIK surgery. Why did LASIK surgery have the cost trends that it's had? Because people were paying for it out of their pocket. And when they were smart consumers. And the marketplace's response. So I happen to think that those tools like HSAs and HRAs and all those are the most powerful. If you look at the bill, I can't say it gets rid of them, but when you hurt those big time, and they do, they take away some of the tax advantages, they limit some of the amounts that you could use, those kinds of things. And I think that's one of the greatest harms. Instead of taking advantage of what could be one of the greatest cost controls that we have, they're instead, those bills go the opposite kinds of way. Next one. There's huge entitlements in expansion. You can look through. And I don't mean it to mean all of this. As we said, there's probably a good 15 million of legitimately long-term uninsured that I think most of us as responsible and caring, compassionate conservatives or caring people would say, I'm willing to invest something to help those. However, if we're moving in a direction where a fifth of our country is going to be on Medicaid, that we're moving in a place where the bills say that if you're a family of 4 making $33,000, you get free, which it's never free, it's taxpayer funded. I always try to remember to use that language because to say this is paid for by the government's wrong. The government doesn't pay for anything. You and I and the taxpayers pay for it all. In other parts of the bill, this is a little bit complicated, but if you look at the bill, for those who are making higher income, there are limits as to the proportion of their income that you can spend on premiums, and if you exceed that, then the taxpayer is going to step in and help you and subsidize, and that means $88,000 happens to be the 400% of poverty level, that we will provide subsidies for families making 400%, up to 400%. It's on a sliding fee, sliding scale kind of thing, but they are potentially subsidized. And then there are some additional tax credits for certain kinds of small employees. I would add one more comment to this. Having tried to do this, once you establish entitlements, they are impossible to remove. I got caught in Minnesota Care when I discovered people with high assets were on the program. We didn't even look at assets. When I discovered that there were people whose income had far exceeded the eligibility requirement were on because the way the language of the bill was, You got this, once you were on, you stayed on. I mean, I couldn't believe it. And we discovered all kinds of things like that. We discovered cases where people missed, they were missing eligibility now, but they were being grandfathered. So what we did is we did reform. To this day, I'm still accused of throwing 30,000 people off the street. That's the rhetoric that you run into. Even when all you're trying to do is simply make these kind of programs more accountable. And I'm not trying to say that I want to throw them all up, because I think we do have some social responsibility here as well for some safety net. Okay, now, there's a lot of build-up about this insurance mandate, the individual mandate, that we're all going to have to be insured. I have repeatedly, I've heard U.S. Representative Walz repeatedly say this. Well, we do it in automobile. What's wrong with doing it with our health care? Well, you know how good it works with automobiles? About 15% non-compliance. And you saw the chart that Dr. White had. We're around 8% non-compliance, if you want to call non-compliance not being insured. We're about twice as good off with our health insurance today. So you rationally think if auto insurance, that might cost you a few $100s a year, if people avoid doing that, what is the 25-year-old who is either wanting to buy a home, or buy a sports car, or do whatever it may be, and they're faced with the prospect of $3,000, and I'm going to be probably on the low side, but $3,000 cost, and I'm going to get a $750 fine if they catch me, what do you think you're going to do? I mean, you can, unless you shoot some. I suppose if you shoot some of them. Originally, I think the health care bill from the House put people in jail. And there was quite an outcry, and the Senate said there's no way we're going to put people in jail. And that's fine. I mean, I don't think anybody believes we ought to go that kind of far. But if your penalties are too low, then it's going to be gained. And even if you make them higher, I just don't see that it's going to happen. I also indicated, by the way, that just because people aren't insured doesn't mean they don't pay their bills. We have a little place over by Waukesha on the Mississippi River, and one of our delightful neighbors is a 90-year-old guy, and I was sitting and visiting with him and asked him about, was he doing his Medicare? He said, no, I don't use Medicare. Oh, why would you do that? I mean, you're entitled to it, because I can afford to pay my own bills. That guy's a multi-millionaire. Now, is there something wrong with that? I don't think so. I think that's pretty morally, I love the guy. Yeah, so I mean, we have to remember that there are people who do pay their bills. By the way, I mean, in sort of the good old days, one of the reasons why things didn't cost as much, because people went in there and, you know, I mean, you want one chicken or two chickens? I mean, it really, there was a consciousness, and there was also kind of a social trade between physicians, healthcare providers, and people seeking healthcare. If you look at those minimum requirements, you'll also find, for those who do believe that have higher income, that do decide that they want insurance, what do they want? They want a very high deductible plan. They want to protect themselves from catastrophe. That's all they need. They don't need you to pay for my yearly checkup, for example. I mean, that's the last thing they need. And yet, if you look at what the requirements are, the way we're heading, all those things will be required and built in. I think I've covered this. Let's go to the next. I call it the ugly public option. And, you know, maybe we shouldn't talk about it, but I think we're better. Because I'm along with Cindy. I'm very cynical about in, out, different twists. We know that it would be competitive. I mean, there's numbers as high as 80 million people in one study that I saw that would leave their current insurance because their employer would decide, I'm going to go with a public option. Why wouldn't I? I mean, it's a fake thing, but it's cheaper. And by the way, some of them would even say, you can fine me. I don't care. 8% of my business is less than 12% of my business, so go ahead and fine me. So the losing of it, the expansion of cost shifting, I think that's why when you saw this thing shift, and I know I'm going to get into it later, and I'll apologize for a little bit of redundancy, but when you saw it shift away from the so-called unpopular public option to the less popular Medicare expansion, all of a sudden Mayo woke up. You may have seen, Mayo said, oh,